obviously the, allergies. It's funny, I had a patient the other day working with a student who had had pain since the healing abutment was placed. She'd gotten on the internet and was convinced that she was allergic to the titanium. And I had a discussion with her about the fact that I've never seen in some, I don't know, thousands and thousands of implants, I've never seen anybody with an allergic reaction to titanium. Not that it doesn't exist, I told her that. Not that I don't not that I disbelieve that you have discomfort. Anyway, unscrewed the healing cap, instant relief. It was compressing the bone and causing pain. Jim and I, in 1992 maybe, we had a lady who, after we put came in completely edgeless, we put in 5 press-fit implants. This was back when we were doing a 2-stage surgery. We uncovered them, put the healing abutments on, and she had pain. Took the healing abutments off, went through all that sort of thing. We finally agreed to send her to Mayo. We sent her to Mayo. She had a full workup done at Mayo. Sent us the bill. She had her heart looked at. And they basically didn't want to make a call, so they said, well, take him out if she wants to have him out. Basically, it will be better for her mental health. So we took him out. Now the story goes on a little bit. She had slipped in a parking lot, so she said, in northern Minnesota, and was suing the store owner. And she had reported, I'm not sure she'd reported that she'd been to the Mayo Clinic, but she'd reported that she'd been to see us. And I added all of her Mayo record to the dental record. So she'd had her knee looked, they'd done a complete workup at Mayo, and there was no issue that she had any knee problems at all. So then she came back another time, maybe 5 years later, wanting us to put in different implants. Maybe different implants would work, but we didn't see her. So Jim, let's talk about case 1 here now. And you'll see that from the, this is the medical history. What do we think about basically when we're looking at medical histories for patients that are going to have implants? Jim, what are the things that you particularly are concerned about? I knew you'd give me up here.
Does this thing work? I prefer to use the microphone. Is it working? I prefer to use it because it's just easier to talk. Okay, so this, we're going to kind of cut to the chase. Thank you for sharing your experiences related to your surgical treatment procedure. Obviously, you have to have the same consideration when you're treating patients, whether you're doing the restorative side or the surgical side. Is there anything in particular from the surgical side that you have to be careful of related to your potential placement of the implant? Obviously, you're going to create some bleeding when you do so. You're going to open the wound. You're going to create some type of bacteremia to some degree. So all those things that you throw back to your education where you had to deal with surgical management of bacteremia, you have to think about. I guess the first thing that we should think about is what are absolute and relative contraindications to implant placement from a surgical perspective. And as Paul mentioned, allergy would be one. There is a sensitivity test for allergic reaction to metals, particularly chromium, cobalt, and titanium. It's possible to get that type of test, but more often I use that to determine whether we should do total joint replacements using titanium implants as opposed to using dental implants. I've never tested a dental implant patient for allergic reaction on the basis of an allergic reaction to titanium. You're probably aware, again, depending on what dental implant you use, that there are different metals that are placed in dental implants. And that's not a company secret for the most part, although commercial companies that make implants would like to tell you their implant system is better. I actually would love to have Charlie Kim come up and tell us what's good and what's bad about all the implant systems. Charlie, I think I've heard all those. Not from you maybe, but I've heard most of them. And everyone's got a gimmick, or I shouldn't say gimmick, an idea, a development that they feel makes their system better. And so you have to make your own judgment. Which system is the best? Who knows? Every rep will tell you their system is the best. From my perspective, you have to find a system you're comfortable working with. I think that your success rates are generally comparable. And so from a surgical perspective, I don't mind when a restorative dentist asks me to put in a specific implant from a specific system, as long as I'm familiar with that system. You know, your situation for all of you is better because you can pick, because you don't have to ask anybody which system you're going to use, because you're going to restore the system you place. I, however, on the other hand, if I'm working with a patient that is well known to me, who sees a restorative dentist in the community, says, I want to use implant system XYZ, it's a big hassle for me to get that system into my vernacular if I don't have it already, and mess with it. So you've won on that end from the first perspective. So my point is, as far as allergic reactions and the construct of your particular implant system, just learn what that is. So what are the absolute contraindications to any treatment procedure, allergy, or any therapeutic recommendation? Allergy is one. It's an absolute contraindication. If someone says, I'm allergic to penicillin, you don't give them penicillin. You could probably just try to decide if in fact they were allergic in some way, shape, or form, if the need to use penicillin was great. But the concept of not using an implant system because of allergic reactions is a relatively small consideration. That being said, are there other absolute contraindications to implant placement? Well, you can think in your own mind, are there absolute contraindications to dental care or restorative dental care versus surgical dental care? And you have to think about that when you're making these decisions. So these particular medical histories are put up here so you at least have a reminder that you are going to be able to review all of these concerns and make a decision. Can this patient surgically tolerate the treatment procedure? Now, from my perspective, the implant patient is typically a patient you know well in your practice. You're going to have to know from two perspectives. One is whatever surgical extraction you do and reconstructive at the time of the extraction, if anything, and then secondarily the placement of the implant. And I will tell you that there are very few absolute contraindications to implant placement, very, very few. That's good. So there's nothing here that's listed. I don't think he has really on our patient number one any positives whatsoever. And so you don't have to, artificial heart, obviously that's artificial joints. There's not really any such thing. If someone's got an actual dynamic artificial heart in them, when they come to see you, they're going to have a big support machine that comes along with it. You're not going to touch that patient, obviously, so they'll probably never show up in your office. But some of these issues related to bacteremia plus potential or propensity for being prone to infections would be your considerations. So what conditions are there that you're concerned about a patient having a propensity to get an infection? Because if your dental implant fails, many times it's associated with an infection. An infection becomes the rationale as to why this implant system failed. Again, it's not related to the implant system per se. So what other things are out there? Interactive, of course, so throw some at me. Diabetes, that's correct. Anyone that's a stage diabetes that's not well controlled. So again, if you have a diabetic patient, make sure that they're as best controlled as they can be before you go down the road of putting an implant. Put all kinds of implants in diabetics. But they need to know that their potential risk is greater for potential implant loss. And so you have to explain it. My perspective coming in on that front end, and I'm not talking about malpractice, but I'm going to give you a disclaimer. I'm the chairman of the board of the Fortress Insurance Company. I don't know if you have Fortress policies for your malpractice insurance. We do right in all 50 states. And from my perspective, I see implant claims on both the oral surgery side and the dental side and dental specialist side. From that perspective, this is not going to be a course about what you need to be worried about based upon malpractice. I'm not going to talk about that. I have to issue the disclaimer. From my perspective, the infectious process is concerned. So if in fact you have a diabetic that's well controlled, then you tell them there's risk, and your risk is greater than the average patient. So as a result, when you see these success rates, the implant system says our success rate is 98.6 or whatever it is, you know, understand that there's a group of patients that may have a lower success rate. What is that for diabetics? Well, it depends on whose books you read or whose paper you read. And some papers say that diabetics don't have an increased risk. Same is true for patients that have had radiation therapy for the treatment of tumor. Now again, you might say, oh no, I don't have any of those patients in my practice, but the fact of the matter is that I just saw a patient last week that Paul and I treated that had radiation therapy, that we placed implants in, that we lost some implants. I don't know if we placed 3 and lost 2, maybe, is that what happened? So she knew, and she actually is a legal, she works in an attorney's office, she's a legal aide or assistant, and so, you know, that's dangerous to treat people in law practices with implants when they have contraindications, but we explained to her ahead of time, you have risk. And so she understood, and she hasn't sued us to date, and hopefully she won't, but she's doing, I think, reasonably well from that perspective. But she understood the risk. So you have to be careful about saying implants work 100% of the time and they never fail, and then have one fail and have someone come back at you. So other than diabetes, what else?
Bisphosphonate.
Bisphosphonate, yes, that's another point. And it's now that whole entity, there's drugs other than bisphosphonates, in addition to bisphosphonates, that create this osteonecrosis of the jaws, or ONJ. Other drugs that have been associated with that, antinogenic drugs, and there are others that are associated. So now it's really, typically, it used to be called Bronj bisphosphonate, now it's called Morange, medically related osteonecrosis of the jaw, MRONJ. The oral surgeons have a good paper about that. If you want to read a paper, you can get it online. Just write AAOMS MRONJ, and you'll get the paper. It came out last year. I think it's the most up-to-date paper that's out there that tells you how to manage patients that are on these types of medications. Is that a contraindication to the placement of implant? Anybody? No, it's not. And in fact, I gave a presentation related to that at one of the international implant meetings a couple of years ago, because I studied all the data that I could find, and I did not find significant indication. However, if you do a surgery on a patient that has MRONJ and they have some necrosis after the fact, then they're going to say, well, you did that because you did surgery. So again, make sure you tell them there's increased risk. And so that's the situation with MRONJ. What else?
Heavy smoker.
Pardon me?
Heavy smoker.
Heavy smoker. Okay, well that's another issue or concern. There are plastic surgeons that won't do surgery on smokers on the basis of the fact that their concern is their outcomes will be bad for cosmetic surgery. And we do know that smoking or heavy smoking or large amounts or for an extended duration will create some challenges with vascularity to the end point, and that includes the maxilla and the mandible, that would create significant problems. So yes, I would warn those patients. Some of the studies that Paul and I did, and Bill was involved with, were in fact, we couldn't enroll or enlist smokers into our study. It was interesting, we'd have patients come in and they'd say they were smokers. Well, you can't be a smoker if you're going to get into the study. And then they'd come in, you could see the cigarette in their pockets or purse, and they'd say, I stopped smoking. Well, when? Well, like 8 o'clock this morning, you know? And so then they became eligible for the study, but the problem was that they couldn't sustain that, and so that's problematic. So heavy smoking, again, I tell my smokers, you have an increased risk of failure. Now, does that mean you shouldn't do it? In all of these situations, the success is over a 50% situation. So again, is it as high as 50%? I wouldn't make that estimate. These things probably drop their success rate, depending on who you read, maybe 10%, 10 to 15, but they do have increased risk, and that shouldn't be your responsibility. Now, if you want to avoid that, there are some oral maxillofacial surgeons that I personally know that don't place implants on smokers. They will say, I'm sorry, I'm not doing it that way, because they don't want the headaches associated. From my perspective, we have multiple patients that are smokers. Any other conditions? I know, yes, sir.
I would say any other active abscesses or infections near the area you're going to place.
Active access, agreed, and that's part of your treatment planning. I mean, if you're in haste to place implants, look at the adjacent dentition, the adjacent environment, and see if there's potential risk. A couple of years ago, there were experts that would give courses like this that would say, if you place an implant next to an endodontically treated tooth, I don't know how many of you have heard this, that in fact increases your potential failure rate. Now, I don't buy that. Who ascribes to that philosophy?